I would like to welcome today to on this sunny Scottish afternoon two of our guests at today's webinar, Robyn Murray and Maria McGinlay. Robyn is an advanced nurse practitioner and Maria is an assistant psychologist. And today we have a very interesting topic indeed, where we will be looking at research and evidence and how these two things come alive in real life settings and how they improve, if they do, residents' well-being and how they do or they don't strengthen staff confidence. So my first question would be to both of you, if you could tell us a bit about your role and potentially thinking what a typical day would look like in your care home. And, when we are talking about research, what does it mean in the context of your daily work? So, Maria, would you like to start?
Yeah, of course. Can you hear me okay? Yeah, hi, I'm Maria, and from I think it was the summer of 2024 until December last year, I was an AP in the Carmichael Community Specialist Dementia Care Community.
Mhm.
And so since then, I've moved to a new role within the NHS, but I've been able to get granted approval to still talk about it, which I'm really happy about. So I think when we speak about a typical day in the Carmichael community, I think like many other care homes, a typical day doesn't exist. It just depends on what goes on that day. Each day is really different. But I would say that the main kind of responsibility of my role was to be a part of the SDCC team, observing behaviour our residents who would come with a presentation of distress in relation to their diagnosis of dementia. And the role of the APs was to develop and action interventions so we could help understand and then also help to de escalate those distress behaviours through the understanding of the why. So another part of that role was to work within multidisciplinary teams to liaise with the residents who are very involved in the process and family and friends, which really helped to get a really all-round view of that resident so we could create a care plan which was really catered to them. But I think the research side is just as important. Um, Being the first AP alongside Abby in the service, we were really involved in the development of that. And that came with its own privileges, but also its own challenges at the same time. So it's learning how to balance that kind of observational clinical work with the work that was to do with data, statistics, and research. So within that, it was really important that we kept up to date on research that was happening outside the SDCC bubble, as we call it. So just making sure that all the practice we were using was evidence-based. Um, and yeah, I think we made sure that, as I said, all our practice was in line with that, but the SDCC was made from contemporary research and the findings there about the impact of low arousal environments and the person-centered approaches we could use to help with reducing distress. And data would play a key role in how we'd monitor that. So and it would stem from assessment for residents. We would use a matrix to measure behaviours of distress, all the way through to just tracking how interventions happened and how beneficial they were. So it's really interesting to have APs be a part of that all the way through, because that can sometimes not be the case in other AP roles. So that was ensuring that psychological mindset and research was in place from the start.
Mhm, mhm. Just for our listeners who potentially not aware of the abbreviations you were using, Maria, so AP would stand for Assistant Psychologist, and STTC is
The specialist dementia care community.
thank you. Thank you. It just I'm very much aware that potentially those acronyms are not something our listeners might be familiar with. So we'll just try to cover those bases. And you mentioned, that awareness of psychological research, psychological practice and research, and I would really like to cover that. But if we can do that later, once we develop into, looking really into nitty-gritty, what research in practice, what that means in daily work, and Thank you for your introduction. Robyn, can I ask you to maybe tell us a bit about your role, your particular role with your care home, and what research means in your daily practice?
Yep, so I'm Robyn and I'm a trainee advanced nurse practitioner and I work at Erskine Veterans Charity. I work with my colleague Kim Barron, and together we look after 180 residents within
Hmm.
the home alongside nurses, carers, senior
Okay.
carers. Our day typically starts with checking, we call them job forms, but
Okay.
it's like your S bars.
Right. Right.
So with any concerns that have come through, and then we have that information and we can prioritise who we need to see
Hmm.
first, who we need to see a bit more urgently. But we'll typically go around. We have 6 separate houses in the home.
Yeah.
Um, and in the morning we'll walk round and just do a check in with staff and see, is there any concerns? Is there anybody you're thinking is not quite right today and you would like us to cast an eye over? Is there anything that we can do today? It's all about that kind of working as a team. So we
Hmm.
rely quite heavily on them to pick up soft signs and things from residents
Yeah.
and let us know when there's been some changes, or if they think that somebody's becoming a bit unwell, or if
Hmm.
something's maybe not going quite as it should for them. And we would review that um, by looking at clinical assessments and prescriptions and things when necessary. Research as a whole, I think, is a huge part of care in general. As nurse practitioners, it's one of the 4 pillars of advanced nursing practice,
Yeah.
um, including clinical leadership, clinical practice, sorry, leadership, education.
Hmm.
Um, it is expected of nurse practitioners to engage and
Right.
keep up to date with research. In our place of work, we work mostly with frailer, older adults,
Yeah. Yeah.
comorbidities and things, and looking at research in terms of polypharmacy as well. We know that a lot
Hmm.
of older residents and things might be on a lot of medication, and that's something that we review, particularly
All right.
antipsychotic medications and things. So we'll do that on a 3 monthly basis to make sure that medications are optimized and people aren't on anything that they maybe don't need to be anymore, or if things need changed a little bit.
Thank you. Thank you, Robyn. So, from what you both said, what I'm picking up, that both environments are very intense and very complex. So, we are not talking, assisted living or maybe supported accommodation. We are talking about supporting residents with very complex needs. And what you described, Maria, was that those psychological interventions which potentially affect residents' care. And Robyn, you touched on that clinical aspect and how research might affect the way clinical decisions are being made. So I think that very much, I think for our listeners, it will be really pivotal to hear that practicality, why research is so important. So, if I were to go back to you, Maria, about and ask you about the use of research in care, not as something theoretical, something removed, something which is happening in libraries and universities, but in action. So, if we were, and I know you mentioned that before, that psychological evidence, when supporting residents or in fact supporting your colleagues, how is it used in practice? And maybe thinking about very tangible example, where you could see that intervention has made a difference to either a resident's life directly or perhaps of how your colleagues would pursue that issue or would feel more confident about addressing that particular issue. Thank you.
Yes, so as in any kind of role with people who could be vulnerable or at risk, it's really important that we have ethical considerations in place when we're using practice and approaches. So it's really important that whenever we would put an intervention in place that is evidence-based and it has some backing with psychological theory and done through supervision as well. So yeah, from a moment that a resident enters our community, the assistant psychologist's job would be to observe to better understand that person, and research comes into play again because we would use something called the Newcastle model to better
Okay.
understand um, what is impacting this resident's behaviour. So we do some investigation on that person's life history, their likes, their dislikes, what's important to them before, what's important now, and that's backed in recent. Oh, my lights have gone off. And so let's see. I think it's a sensor. There we go. Um, sorry
Lights are
about
back.
that. I'm back. Um, so yeah, the Newcastle model is taking all that information into account, and um, through things like positive behaviour support is telling us that evidence backs that you're better to look at interventions that take all that into account as well. So I remember a big example of a real life situation that happened
Hmm.
was we had a resident, one of our first residents in the SDCC, who showed a specific dislike to a certain member of staff.
Okay.
And we were beginning to wonder why this could be. We try and understand the why rather than just seeing it as we'll manage that behavior. We're
Right.
looking to understand why that's happening and work around it that way. So we did some observation, and this resident was shouting, making threats towards this member of staff, but then it started to grow into myself and the other assistant psychologist as well. So
Hmm.
through supervision and formulating with our supervisor, like what are the links here between each other? And one of the things we noticed was that we were all wearing the same uniform. So we're through supervision again, was talking to the clinical psychologist, and they said, well, in research, it can be quite common for people who have dementia to revert to coping strategies and skills that worked before with things that were upsetting to them. So I was like, right, I'm going to delve a wee bit further into that. So we looked into speaking to this resident's family, who then let us know that that resident had a previous history of incarceration. So through
Okay.
research of past trauma and things associated with that, I remember there's a really interesting piece of research that was done in America a couple of years ago about individuals who had been exposed to war crimes in similar situations, reverting to behaviours they would have done to cope and survive in those situations 50, 60 years down the line when their
Wow.
dementia processed that way. So then just in that moment, just suddenly thinking, oh my goodness, with our white polo shirts and our black trousers, are we quite reminiscent of prison guards here?
Uh-huh. Uh-huh.
So for a week, myself and the other two members of staff who shared that uniform went out of uniform for a week. So we just came in jeans, jumpers, and we tracked the data from before and after that variable was put in place to see if there was a difference. And we did see that the resident then responded better to us out with our uniforms. So that was just really interesting to keep in mind. Although the behaviour did continue, it really opened up what an intervention could be, because a lot of the time I think it's this big thing, oh, we all need to do this, but just to even take that difference of a
Yeah.
clothing choice to see could make a really big difference. So without that research that I could look at and peruse about trauma, trauma-informed practice in relation to dementia, that intervention wouldn't have happened. So it's really interesting to have that role to be able to think and formulate and then go back to research and put it into practice that way.
Wow. Thank you for sharing that. That is fascinating. And I think that actually demonstrates really well that research is not something far removed from practice, and it's an add-on activity which we could resource to when we have a bit of spare time, or we've got nothing to do and we want to improve our practice somehow. This is a very as I ask you for that to be a tangible example, this is a very much application of research in practice, and especially tracking that data as well. It's supporting that destigmatizing the concept of dementia using scientific findings. If I were to ask Robyn, a slightly different angle, and I know you mentioned a lot of pharmaceutical um, observations being done in your care home, Robyn, because obviously Erskine is a very famous and very large establishment. So what I was going to ask you, with such a size of establishment, because you mentioned that your morning round could take a while, um, that evidence and data. Do you think they guide you with supporting care home staff who's not probably, clinically trained to your level, and supporting them with not improving, but making better clinical decisions? And it doesn't have to be, pharmaceutical decisions, but maybe care decisions. But I would be really interested in your role as a trainee advanced nurse practitioner, because we know there are very few of you in Scotland who are employed by care homes. I think this will be a very interesting fact to know as well, that that level of clinician is not often recognized, by care home, but from your work. And that's what I was fascinated by your story when we met at the Scottish Care Conference, the amount of need in establishment like yours, which your particular role could add the value onto. So what I was trying to say, if you were to think about that example where you are a really busy care home, you've got people with some really strong clinical needs and decisions needed to be made all the time. How do you manage to use that evidence and data in your daily work? Or you just, go along with things and then maybe reflect on that? Or do you feel that you apply it and confidently managing to do that? So maybe if you need time to maybe think about it.
I think between having worked as a nurse and you're always working with evidence-based practice, and then
Yeah.
doing my advanced nurse practitioner training, you look a lot at clinical assessment,
Mm-hmm.
and that does include being able to prioritise care, identify where the greatest need is. So it's not to say that we would ever miss someone out, but
Yeah.
with having that skill set and ability, you are able to look at scenario, and you have to see resident A, B, and C all are quite unwell,
Mm-hmm.
but resident B is fairly stable. We will need to look at them, but resident A is actually maybe a bit of trouble, and we
Yeah.
can identify that and prioritise our care and attend them first. I don't know that I would expect everybody to have the confidence to make that decision, and it's certainly
Okay.
something that I wasn't comfortable with initially. Thankfully, I've got support with Kim, but it is something that I'm building a lot more confidence around and being able to make those decisions based on my training, which is all backed by research.
Mm-hmm.
You are able to say that this is where I need to go first, and make that decision, and then you stick with it.
So a striking example where you walked into a room and something really jumped at you as, this is where I need to use my good knowledge of X, and reflecting back you think, yes, that was really strong decision, clinical decision made based on my knowledge.
Probably one would be when I attended, and it was a phone call rather than an NS bar or something, asking
Okay.
me to come in to see somebody, and it didn't seem overly urgent.
Okay.
But when I attended, I walked into the room and I knew that this lady had to go to hospital,
Okay.
based on laboured breathing, increased respiratory rate, struggling for air entry, and the staff were incredible, but being able to identify that's something that is a medical emergency,
Uh-huh.
um, she was fully my priority from that moment. And she unfortunately did have to go to hospital. We do try to keep people at home as much as possible.
Yeah.
I think
Yeah.
the older generation have quite a strong dislike of going into hospitals. They don't want to bother anybody, and
Of course. Yeah.
and it's sometimes about having those conversations as well, with residents, to say this would probably be what I think would be in your best interest. And a lot of the time you do get agreement there, because they trust you, because you've done the training, you've got the skills, and they do tend to trust what you say. So then it makes it feel like it's a bigger decision on your hand, on your side as well. Yeah.
Thank you, Robyn. I could see Maria nodding. Maria, have you got something to add to that?
No, I just find it really interesting how like research kind of encompasses all roles and how that decision making is informed by that. So I just find it really interesting to hear how the same threads are there, just in a different kind of way about. So
Yeah, that and from different angles, because I'm not clinician myself, and for me it's always that I think additional responsibility for somebody who is in a clinical role, to have that almost self-empowerment to make that decision, and at the same time, as you mentioned, Robyn, to build up that trust with that person, because we all make mistakes, which is absolutely human, but at the same time, it always, to me, looks like that clinical decision has the urgency, with and I'm not saying that psychological decision absolutely doesn't have that urgency, but I think that physical presence of symptoms, it just presents differently, and therefore it forms that physical urgency that you have to act there and now. And just to go back to what you said, Robyn, was you prioritizing care and potentially making decisions which you then review. Do you think, again, trying to bring research back into our conversation, do you feel that you being research proactive helps you to reflect better on your clinical decisions and you review them better?
Oh yeah, absolutely.
Uh-huh.
Because essentially the decisions I'm making are often on the spot, but they are backed by research and training. And I do actually have, I've got a little book that I use for reflection.
Okay. Right.
When something's maybe particularly stood out to me, or it's been a bit more complex.
Okay.
And I'll often have a wee note, just so I can look back and look at the way that things had gone through and the outcomes, and would I do anything differently, and looking at research and what practice would say should be the way of doing things in that scenario.
Okay. So would you say then that that not being scared of research helps you better reflect on your practice?
Yeah, I think initially when you start to think about research, it sounds like something so scary. There's research into everything, and it seems a bit overwhelming, but it's certainly, for us as healthcare workers, it's fundamental. It's what's shown us the importance of person-centred care, which then leads to better patient-resident outcomes. And that shows with us in residential care homes, where the people you're looking after, you're providing person-centred care, and sometimes that can be coming to agreements of, I don't want to go to hospital just now.
Yeah.
I'll try this, and if it doesn't work, then we'll go. And It's when research has showed us as well, you can't push people into making the decision that you think is right. You can give people the information as best as possible, or quite often it's relatives of residents, because we have people with quite significant cognitive decline and dementia and things as well. So being able to have those conversations and backing up with research, why we think this would be the best way to treat at this time, as opposed to an oral antibiotic. If we see signs of sepsis, research has shown us that IV antibiotics would be prudent in this circumstance to avoid further deterioration, and being able to provide that information, those facts based on the research, can be quite comforting for people as well, because not everybody has a knowledge into healthcare and body systems, pathophysiology and all that. So they do look to you to be able to provide the answers to then make their decisions.
Thank you for that, Robyn. I would really like to get back and tell me if it's not a common thing. I see a common thing in both of your work, and Robyn touched on that, antipsychotic medication. And I know that we, from our work here at ENRICH Scotland, we work with many care homes, and there is quite a strong stand on trying to oppose the strong use and making sure that it's really in controlled environment and reducing the use of those medications. My understanding as a non-clinician is that it's very much health-led. Those decisions are being often health-led. So that is the question to Robyn. Do you feel that? And to Maria, as a non-clinician, do you feel that often that hierarchy of decision stays with health, and you, as somebody with research knowledge or an evidence-based approach to person-centered practice, are able to back your decisions, potentially to challenge those? I don't know who wants to go first. To Maria, to Robyn.
I don't mind.
Go for it.
I think obviously predominantly where I work, it's health-led, but it's based on studies and research, by multidisciplinary teams, and that includes psychologists, psychiatrists, mental health nurses, consultants. So the research, I think, does come from quite a varied group of people. It's not purely clinical clinical nurses or doctors that make those decisions. Particularly this is more medical, but research into medications to allow them to be licensed for use will give us the list of side effects, contraindications with other drugs that are prescribed at the same time. And that's something that we really have to consider as well when prescribing or deprescribing. And when we're looking at antipsychotic use, we do have to consider variables as well, as sometimes these drugs can make people more irritable or distressed, uncomfortable. Obviously, quite common side effects are lethargy, drowsiness, a bit of sedation with some antipsychotic drugs as well. And we wouldn't have that knowledge without the research that's going on in the background. We are lucky to be able to access that and use that, but I do think it's come from quite a mixed background that all of this information has come together, and we do look at it as a whole. I would like to think.
Okay.
Maybe I will agree.
Yeah. So clinician versus non-clinician. Maria?
The ultimate showdown? No. No, it's totally a team effort altogether. As like a non-clinical member of staff, it wasn't within my job role to change medication or to even present that as an option. Kind of our role was to try and mitigate the use of that as much as possible through psychological practice, while
Okay.
keeping an open communication with the nursing staff. Because we say all the time that we couldn't do what we do without the care staff, without the nursing staff providing the care that they do. We just come in with a different angle that works hand in hand with it. So during our time, one of our main goals with our residents within the SDCC was that it wasn't a permanent placement, that hopefully after understanding the why to distress behaviour and helping to de-escalate it, we could then help them to transition to a dementia nursing community, or even just a nursing community if the physical needs took over is the bigger need there. And part of that was to try and reduce the antipsychotic medication as much as possible. Also with looking at variables that are important, such as health, so that would be kind of the nursing side of that. And also trying to reduce the amount of PRN medication given in relation to distress. I think that's really important to look at as well. But again, it wasn't within our kind of job description to examine that. It was more how can we use alternative approaches instead to try and reduce that. So I think during before I left, we were drafting up the SDCC report for the year, and within my time or the last year within the SDCC, I think we had under 10 uses of PRN medication for all residents using therapeutic approach instead. So just being able to use that psychological therapeutic approach before getting to that is the option, just at least trying something else first was kind of our way of looking at it. But 100%, it's not clinical versus non-clinical. It's trying to work them hand in hand to get the best care for the resident.
And I did it on purpose. I wanted to create a bit of that clash because often, it's that, societal perception when you put the news on, it often is being seen that way. And it's really interesting to unravel it, from your perspective. Sorry, Robyn, you wanted to add?
Yeah. I just wanted to share an example
Brilliant.
So we've discussed about cognitive declines, dementias and things. Quite often, unfortunately, residents aren't able to verbalise their needs or aren't able to find the words to tell us exactly what it is that they need. Are they sore? And sometimes those can develop into what appears to be distress behaviours. So we use a tool. I don't know if I'm allowed to name drop the company that we use or not. It's AI technology.
Okay, we'll check and they just make a note of it. But advertisement.
So we use an AI technology. It's an app, and it scans for features of pain. So historically, you would use the Abbey pain check to monitor and document pain. We have this now, and it's like a different level because it doesn't overrule clinical judgment, but you are able to, do a wee scan of the face, and it'll pick up on like the slightest muscle changes in the face, any noises and things. And we have found that has been a great tool for us because if people are in pain and they appear distressed and you're actually able to manage their pain, they don't actually need antipsychotics like you might have thought initially.
No, not a secondary, but nip into the bud.
Yeah, quite often these distressed behaviours are related to pain, and we can acknowledge that and we can deal with that as opposed to essentially putting a plaster over something rather than treating the wound. And we found that to be really helpful, and that's something that we use all the time. And we use it quite regularly for people who are maybe quite new with us, or if there's been a bit of a change in somebody's behaviour and we're not quite sure what's going on, and it just gives us that extra information and a bit of guidance to base our decisions on the next step, which I think it's been really, really helpful.
That is a fantastic example, Robyn, because it actually gives a secondary layer to what we're talking about, because that we're talking about innovation, and any innovation means that firstly, any product or development would have to go through our vigorous research project based exercise where those things you are talking about would be tested out to make sure that when it is applied in real life, that it's safe, that it's really that is helpful, that it's not just masking something, but it's a tool which helps situation to de-escalate that situation using additional chemicals. Can I say chemicals? Potentially, yeah. That if we were to just be right sitting around kitchen table, that these are chemicals. So to address the actually core issue without prescribing antipsychotics, because you were able to read into the symptoms, that is an amazing example. But trying to go back from talking about unicorns and fantastic work you're doing because you're young, you are curious, you want to learn, you have learned, and you can see that application of research in real practice really works. If we were to get back to gloom and doom of an average establishment in Scotland, do you think that research is here and frontline is here? And what makes it difficult for people, for staff and families and residents for that matter, to see that research is something airy-fairy for clever people who go to uni, and my job is not related to that. So what makes it difficult for that separate? Is it separated? Because from what I'm hearing, it's all fantastic, and ENRICH Scotland should have so much work in next 5 years if people like yourself are involved. But we have different data and different stats that it depends on care home culture, it depends on resources within care homes. So I don't want to put words in your mouth. Is it research and frontline care? Are these two different things? And what makes it difficult to stay that way, and what actually works to bring it together and normalize it and making it part of your daily practice? That research is not something which should be an afterthought.
Happy for me to go?
Absolutely. Yes.
I think one of the issues with it is a lot of places you always have some people who will think, oh, but this is how we've always done it.
Okay.
I think you hear that a lot. Well, when I was doing my nursing training and I was working elsewhere, you would hear it in terms of moving and handling. Oh, we don't need to do that. This is how we've always done it. But actually, the evidence shows that in order to avoid injury to both you and the resident, the safest practice is to do it this way. I think there's always going to be a bit of pushback there, because we're creatures of habit, essentially, and we do get a bit stuck in our ways, and we're not always so keen to change things. I think where I work, we've done a couple of conferences in the home, particularly for care staff. So to involve them a bit as well, and to go over not as fully in depth in clinical assessments and pharmacology, because it's not as relevant to them, but to give them the tools to see this is why things like antibiotics wouldn't be given to everybody, and a bit of information to keep them up to date with research and policy and things as well, which I do think we've got quite a lot of good feedback for.
Good feedback.
I think it's something that we'll probably continue doing.
Right.
But it also helps when you're building relationships and stuff with staff as well. And then if you're more approachable, I think people are more likely to come and ask you a question, or be a bit more inclined to accept a bit new information as well, but I do think a little bit of pushback may always be a challenge, no matter where you are.
Okay.
It's just about trying to encourage people to look at things differently, and we're not changing things to be difficult. It's for the better outcomes for the residents who live here, for the staff.
But I also hear what you said, Robyn, is that investment in your frontline staff that, as you say, keep people up to date with policy and research and development, and sharing that level of knowledge which is applicable to their role, but at the same time encouraging people to access more. That feels like a win-win situation, because I do believe in altruism, but I always feel for a person to um, give back, something has to, be received, when you're a recipient of something, and knowledge often is something people are missing, and therefore that pushback often happens because of that confidence not being there, perhaps, and lacking that knowledge and understanding. So I would be really interested, Maria, what is your take on that?
Yeah, 100%. I think people often view research as something distant from care because even just like the term research can sometimes bring a
Yeah.
bit of intimidation.
Uh-huh.
You get kind of images of like lab coats and test tubes
Yes.
and a big green potion, but it's something a bit more practical than that and a bit more relevant to everyday work. I think coming from a psychology background, it's easier because through training, it's seen as you investigate something to then put it into practice somewhere else. But if you're in a fast-paced, hands-on position, it's in that kind of success is measured by immediate outcomes of keeping residents safe, supported, and cared for, which are totally valid measures of success. But if that's what the only thing we're focusing on, then you can sometimes see statistics and that kind of jargon as something that's unnecessary and can be pushed to the
Yeah.
side. Um, However, research can transform care and can transform outcomes for residents. It's just trying to find how to balance that human nature of care with numbers, which is tricky, but it can be done. I remember as well, as Robyn was saying, giving that opportunity to staff to get involved and have exposure to other theories and research is so monumental. We had somebody come in from Namaste Care, do a 2 day
Mhm.
session with all the staff. So that's kind of a sensory intervention of being able to meaningfully connect with residents. It did stem from end of life care before, but they're trying to move it more towards maybe a more developed dementia. So if somebody's struggling to communicate or make a connection through language, you can do it through sensory things like a hand
Uh-huh.
massage or music or taste. Doing that just really changed that whole relationship and then kind of caused a ripple effect with other staff members as well, who then
Right.
were also thinking, oh, we could put that research into practice with this resident who is pacing up and down the halls, doesn't want to relax. Why don't we try a hand massage and see if that works? And that resident fell asleep in the chair. So it's just showing that if you give staff the opportunity to engage in research based practice and give them the confidence that you can make a difference, it really can.
Um, I think you answered my next question. What is the answer to that, to breaking that barrier? And so did Robyn, because we spoke about so much that normalizing and understanding how research plays a vital, huge role in everyday life in care home, because that is somebody's home. That's what I think often, again, TV propaganda doesn't help, where we forget that care home is not an establishment, it's not an institution, it's somebody's home. And therefore, you are supporting people in their home. And that person-centered approach is not something which is written in books. It actually, as Robyn, you were mentioning, for example, about moving and handling, how do you do it in a safest and most dignified way? Not just because we've always done that, but because this is the proven way through research that works better for everybody, and especially for dignity of that person involved. And I think for care home staff is that practicality of approach, and that maybe touchy-feely of that knowledge being tangible is not the right word, but it's something you could take away and, bring it back and keep applying, and you can see that it keeps working. That is something, I heard from both of you, that something which works with frontline staff. But I'm very much aware of time, and really what I was going to ask, but you answered that. I was going to ask you, that in strong engagement and strong feelings you have that research is a part of your work and a part of your daily environment. And I hear that it gives you that confidence and self-support for developing your role. But for our listeners who most of them, I would imagine, work in care homes or support research in care homes. If we were to maybe focus on one takeaway for people who are involved in some capacity with care home community, why is research so important? Why people should understand better about it, why people should aim to engage in these practices. One takeaway thing for our listeners. Thank you.
I think research allows us all to kind of move away from assumption and guesswork.
Wow.
We
Okay.
work based on evidence.
Yeah.
Trial and error has been done for us. We have the research, and this is potentially a good way of looking at it. I think it's quite a positive way at looking at it. So it's not all about making changes all the time, but it's a way to enable us to provide the best possible outcomes for people, the best person-centered care. We want people to have a quality of life when they move into care homes. And it is part of our role to make sure that that's the case, and that's why research is so important.
That is really strong. Thank you, Robyn. Maria. I'll take a note of it. Research helps us to move away from assumption. I love it. Absolutely love it. Thank you.
I'm thinking no pressure. I've got a line at the end. But yeah, you've said it. Research kind of takes away from that kind of guesswork and moving towards something that is practice. There's a reason it's evidence-based, because there's the data there to back it up. And I think being able to use research and change practice and being able to reflect on it is how we improve. If we didn't look back and evaluated our processes and our approaches, we would stay the same, and we need change to keep developing. It really does just benefit all involved. It helps the staff have more experience with different approaches and different areas of expertise that they wouldn't have had before. I know from a personal perspective, I didn't think I'd be involved in Namaste Care or Tipa Snow teachings, but being able to be in that role, and I find that such an honour to be a part of that journey within the SDCC. Because a person's life doesn't end when they go into a care home, it's just a different stage. So why should we not continue to develop and make the care as best as we can for them through different approaches?
Well, that's been a pleasure. I think I will definitely take the last messages from both of you to distribute wider. And next week we have our ENRICH conference, Scotland ENRICH Scotland conference, which will take place in Stirling. And I think that these conversations will continue long into the day. And really, I think for somebody like myself who's really passionate about research, I often get frustrated when people try to shut that off and say, oh, we don't have time for that. Where in fact, today's conversation just proved, and I hope our listeners will get the same away, that research is not a question of choice anymore in today's world. That is something which is, as you mentioned earlier, Robyn, one of the four pillars of clinical practice. And as you mentioned, Maria, that psychological intervention backs practice, immediate decisions. That is not a question of if you're getting involved in research and if you are supporting your practice with not, but it's a necessity in today's world where those mistakes are being done. I love that as well. Those mistakes were done for us, therefore we don't have to repeat them, but we can use good outcomes and implement them into our practice. Thank you both very much. That's been an absolute pleasure. That was Robyn Murray and Maria McGinlay from Scotland Care Homes, who are research active, who are implementing research in their daily work, and hopefully you're young enough to change this world to be a better place where research is a norm, not a accessory which is not often being chosen. Thank you.